So I run our hypertrophic cardiomyopathy clinic. I've been seeing HCM patients for about the last 8 years. And so we're going to go over some of the things that I do typically, but also some of the warning signs and some of the recommendations. So hypertrophic cardiomyopathy, what is it? We've heard a lot about it. We're concerned about it. It's a cause of sudden death. When we look at the diagnostic and definition of it, it's really unexplained left ventricular hypertrophy. When we get down to the genetic level, it's due to pathologic variation in the sarcomeric proteins, the proteins that encode the sarcomere, or the genes that encode the sarcomeric proteins. It results in left ventricular hypertrophy that is often asymmetric, but doesn't have to be. And it can or it may or may not have left ventricular outflow tract obstruction associated with it. It's important to understand that it can develop at any age. Most commonly, it develops in the teenage years, sort of between the ages of 12 and 18. As the body grows, there's a tendency for the heart to grow as well, and it can really manifest during those time periods. It can develop earlier than that. It can develop later than that. There tends to be a second peak in midlife in the 40s and 50s as well. The estimated prevalence has always been quoted about 1 in 500, but that really represents cross-sectional prevalence. And when you look at lifetime prevalence of disease, it's probably closer to about 1 in 200. So this is an example of a patient with hypertrophic cardiomyopathy. You can see this is what we call a peristernal long axis view of the heart. And see if I get this going right here. So this is the septum. This is thick. This is much thicker than it should be, and this is the posterior wall here. Normal heart muscle thickness is like this, and this is abnormal, so that's closer to 40 or 50 millimeters at that point. Notice that I will point out that this individual does not have any left ventricular outflow tract obstruction, so despite the very thick heart, he didn't have any obstruction. So the HCM comes in a variety of different shapes and sizes, and the Mayo Group has put forth this sort of schematic to represent some of the changes. It can be a small amount of hypertrophy here in the basal septum. It can be a much larger amount of hypertrophy, we call reverse curvature HCM. That's usually at the mid-ventricle. Apical HCM, which Aaron had mentioned briefly. And then there's neutral morphology as well, where the septum is fairly neutral throughout, and this is less common, but maybe more associated with sort of thin filament disease. When we look at the ECG findings in hypertrophic cardiomyopathy, we can see some distinct findings. And this is a study done by Carolyn Ho and colleagues from 2011. And she looked at the ECG findings, not only in patients with hypertrophic cardiomyopathy versus controls, but they also included a group in here who are known to be gene positive, but yet hadn't yet developed any hypertrophy. So a couple of findings I just wanted to point out. Hypertrophic cardiomyopathy patients can have normal ECGs. So about 10 to 15% of the time, and this is borne out in a number of studies, they can have a normal ECG. So just because they have a normal ECG doesn't mean that you can't have HCM. The second is that LVH criteria, although they're very common in patients with HCM, up to a third of patients don't have any voltage criteria for left ventricular hypertrophy, even though they have left ventricular hypertrophy. And that as a diagnostic test, as we've heard before, it just is not a very good tool to discriminate athletes from patients with disease. The thing that does help us differentiate the two groups is really these findings that Aaron had just talked about, which are the ST depressions, the T wave inversions, and the Q waves. But I want to point out a couple things here. One is that these are very uncommon in controls, and these are healthy controls, not necessarily athletes. But then the preclinical hypertrophic cardiomyopathy, those individuals who carry a gene but don't have the hypertrophy can have ECG abnormalities that occur in advance of the hypertrophy. When we look at the HCM population as a whole, probably about 40 to 50% had Q-wave abnormalities, ST depressions, and T-wave inversions individually. When you add those up, probably about 80 to 85% of them had one of those abnormalities, one or more of those abnormalities. Here are some examples of some of the ECGs from my patients. This is one just showing some T-wave inversions, as Aaron had pointed out. We're really concerned about the T-wave inversions here in the lateral leads. This is an individual that doesn't have apical hypertrophic cardiomyopathy, but does have more septal predominant disease, and so there's the findings there. This is a 22-year-old asymptomatic female athlete who is actually an ultimate Frisbee player. She got diagnosed with HCM after she had an ECG going out for the national ultimate team. And so she has these Q waves here in one and AVL, so some lateral leads here that were clearly abnormal. Caused additional evaluation. She was found to have septal hypertrophy. And here's the classic sort of apical hypertrophic cardiomyopathy that we've seen previously. And I want to point out that if you see this, you, even in the presence of a normal ECG, you should be digging further because it's heavily associated with disease. So how do we evaluate suspected hypertrophic cardiomyopathy? Well, first off, it can be a very complex evaluation. It involves multimodalities, multiple types of tests, both looking at the imaging, looking at the rhythm, doing genetics and everything else. So before we launch into this, I think it's really important to look at the ECG and try to figure out what's the pretest probability of HCM based on these findings. So if you have an isolated Q wave abnormality as an isolated finding, no ST depressions, no T wave inversions, et cetera, you have a fairly low positive predictive value from that. If you have isolated T wave inversions in the inferior leads, you also have a fairly low positive predictive value for this. So you may not want to launch into an extensive evaluation if the echocardiogram is normal. On the other hand, if you have to have a high index of suspicion if you see those deep lateral T wave inversions, if you have ST depressions and T wave inversions, or you have a combination of abnormalities. And so the workup of suspected HCM begins simply with the history and physical. And when you're talking to an athlete, it's important not only to talk about, hey, what kind of symptoms are you having, but you really want to take a detailed exercise history, and that involves how much exercise are you doing, what duration of exercise you're doing, are you taking the summers off, are you training year round, because that's really going to affect the cardiac adaptation to exercise, and that has a big impact on what you'll see and what you find. You also want to take a very detailed family history that involves 3 to 4 generation pedigree. If you have an athlete come into your office and you ask them about their family history, it's likely going to be not very helpful. And so what you need to do is say, hey, I need to know about your family history. Go talk to your parents, go talk to your family, come back and with that information, or give them a heads up ahead of time, because the parents are the ones that are really going to be key to this evaluation. You start with an echocardiogram. That's really the first test when we're doing this. It can evaluate the left ventricular wall thickness of most segments, and I say most segments because it can't evaluate all segments. We use the short axis view primarily when we're measuring wall thickness. It is best look at the inferior septum and lateral wall, but it's imperfect, and that's the area where we can run into trouble with on echocardiogram. The echo beam doesn't bounce off those parts of the heart very well, and we can lose the epicardial definition very easily. We look at systolic and diastolic function with echocardiogram. We can look at strain rate as well. And then based on your pretest probability, based on your echo, the quality of your echo, you can make a decision about whether or not to go forward with a cardiac MRI. So it's indicated a class 1 recommendation by the HCM guidelines to go forward with a cardiac MRI when the echo is inconclusive. The MRI has tomographic imaging. We get much better detailed about the wall thickness. We also get information about the presence of fibrosis. So HCM can present with these very bizarre patterns of hypertrophy, and over here on the left you see fairly normal wall thickness all the way across, but then right over here you see a very abrupt change to something that's thick. And we think of this as genetic. This is a genetically proven in this particular woman, and so the question is, why does only this segment of the heart thickened up and the one right next to it is not? And I don't have the detail of this. And this is another pattern that can occur, and this is sort of a dumbbell-shaped septum. And I point this out because when you do your standard imaging plane right here, you're going to cut right through the thin part of the septum, and that's going to look very normal. But you're thick out here and you're thick out here. So you're going to rely a lot on those abnormalities on the ECG to tell you that, hey, there's something going on here. This is a woman who had heart failure after pregnancy and was told that she had a normal ECG. But then developed complications from ventricular arrhythmias, and only when she had a cardiac MRI was it apparent that she had hypertrophic cardiomyopathy. So like I said, the CMR can be very helpful in diagnosis hypertrophic cardiomyopathy when the echo is inconclusive. The spots that we get in trouble with are the apex here, the inferior septum, and sort of this anterior lateral wall. And it's about 10 to 15% of HCM that demonstrate this very focal hypertrophy that's more prone to being missed by echocardiography. Here's an example of a patient that came through our echo lab at the University of Washington. This here was read out as a normal echo, but they had distinctly abnormal ECG with those deep lateral T-wave inversions. We went forward with a cardiac MRI. You can see over here that they had the apical hypertrophy, which is the apical variant maximal wall thickness of 18 millimeters. That was the EKG right there. When you get going forward, you can also consider doing some adjunctive testing as well if the diagnosis is in doubt. And that some advanced imaging modalities such as echo strain or strain rate imaging. We can do CMR tissue tagging or T1 mapping. Go to cardiopulmonary exercise test to figure out what their true exercise capacity is. I think there's a myth out there that normal exercise capacity is incompatible with a hypertrophic cardiomyopathy diagnosis. We do have some HCM patients who have above average exercise tolerance, but that's unusual, is what I'll say. We can do ambulatory blood pressure monitoring when we're concerned about hypertensive disease. We do family screening. We can do genetic testing. Sort of a last resort is deconditioning and reevaluating. And for all of these patients, then longitudinal follow-up is important. I did leave out here, and I should have included the Holter monitor, because I think that's an essential sort of component to this. So we've heard a lot about this idea about physiologic cardiac adaptation to exercise. And if you do a lot of endurance exercise, you're going to get this eccentric dilation and hypertrophy. If you do more strength training, you'll get more concentric hypertrophy. In actuality, most athletes do a combination of these two, and most sports provide both eccentric and concentric hypertrophy, so that's a little bit of an arbitrary distinction. We know that the types of exercise influence your heart's remodeling process, and both in terms of the cavity size and left ventricular hypertrophy. We know that black athletes have more hypertrophy than white athletes, and that men on average have greater wall thickness than women. So we have to take all of that into consideration when we're doing these evaluations in athletes with suspected HCM. But we end up sometimes in this athlete's heart conundrum where there's an overlap or the gray zone between people with hypertrophic cardiomyopathy and those with this cardiac adaptation process. So the gray zone is typically described as being between 13 and 15 millimeters. I think it's probably a little bit thicker than that for a black athlete. And it sometimes takes a lot of careful consideration to try to figure out how, whether this represents disease or something that's somebody that's just super healthy. Kind of a paradox there. But there's no one single discriminatory test that's going to be able to give you that answer. So we rely on the pattern of left ventricular hypertrophy. I showed you some examples of some of the bizarre patterns that can occur in hypertrophic cardiomyopathy. The cardiac adaptation process tends to be more concentric, although septal predominant, so there can be some asymmetry in the, even with the cardiac adaptation to exercise. We look at the LV cavity size. Those sports that cause the most left ventricular hypertrophy often will cause left ventricular dilation as well, so we pay attention to the cavity size. If you have an above average cavity size, that's usually not associated with hypertrophic cardiomyopathy. We looked at left atrial enlargement. It's a little bit hard to do because as part of the cardiac adaptation process, the left atrium does enlarge, but some patients with HCM do have extremely large left atriums due to the diastolic dysfunction that occurs. We look at cardiac MRI and marker of fibrosis. So if you do see late gadolinium enhancement on a cardiac MRI, that's really a key that this may not be cardiac adaptation process. And again, we can look at the peak VO2 and somebody has an above average, especially if it's over 110% predicted. That certainly leans in the direction that this is an athlete's heart. If you go through all of that and you still don't have an answer, you can talk to the athlete about the possibility of doing some deconditioning. I'm not a huge proponent of deconditioning, except in sort of the last-ditch efforts. I think with cardiac MRIs and strain rate imaging and some other things, we're pretty good at differentiating the health from disease at this point. But sometimes that's what you have to do. It's a little bit challenging to have athletes not exercise for 6 months. You take somebody who's been exercising every day of their life for most of the last 5 years, 10 years, decade, et cetera, and you ask them not to exercise, that's going to be hard for them for lots of different reasons, and some probably still exercise to a smaller degree. And then there's this possibility of genetic testing, and I'm going to talk a little bit more about genetic testing tomorrow, so I'm not going to get into too many of the details here. Once we go through this, I want to remind this is the guideline definition of hypertrophic cardiomyopathy. That's wall thickness greater than equal to 15 millimeters. If you do genetic testing in that individual, or genetic testing has been performed in the family, then you can call that sort of confirmed or definite hypertrophic cardiomyopathy. If you don't know their genetic status, but you've excluded every other cause of hypertrophy in that individual, well, that then is presumed hypertrophic cardiomyopathy. And if you can identify another cause for the hypertrophy, then that we no longer call that hypertrophic cardiomyopathy. And that includes hypertensive heart disease, pressure overload states due to aortic stenosis. Maybe they have bicuspid aortic valve with stem stenosis, infiltrative disorders, and these genetic phenocopies, something like Fabry disease. That is sort of the guideline definition. In practice, there's some things that don't quite fit into that. 15 millimeters isn't an absolute cutoff. We make plenty of diagnosis in HCM at lower thresholds, especially if there's a family history or there's something else that is markedly abnormal. Remember that the diagnosis of HCM is independent of the presence or absence of left ventricular outflow tract obstruction. Obstruction is present at rest in about a third of individuals and present with exertion only, and another third, but a third don't have any obstruction. Genetic testing can help confirm the diagnosis, but negative genetic testing results don't get you anywhere. They don't exclude diagnosis, and the gene testing is not necessary for the diagnosis. And once you confirm the diagnosis of HCM, that's just the beginning. We have to do some risk stratification for sudden cardiac arrest, and then we have to think about family screening because HCM is a familial diagnosis. So you make a diagnosis in one individual, you're giving that whole family the diagnosis. Wanted to mention just this entity of preclinical hypertrophic cardiomyopathy. These are genetic carriers or people who have the genetic known pathologic genetic variant capable of causing hypertrophic cardiomyopathy. But when you do their echocardiogram and your cardiac MRI and do their full evaluation, they don't have any evidence of hypertrophy. They're still not normal. When you look at their hearts, if you look carefully at the way their heart is squeezing and relaxing, you can usually identify these abnormalities. These include some abnormalities on the ECG, so that could be one of the reasons why we're having these ECG abnormalities but don't yet develop or detect hypertrophy. They often have high resting ejection fractions, so their ejection fraction is usually greater than 65%. So we tend to, all the time I hear these patients who said, oh yeah, my doctor told me I had an athlete's heart. It was really contracting well. Well, to me, that's disease at this state. If you're actually an athlete, in the remodeling process, your ejection fraction will start to decline because you don't need that ejection fraction at rest. You can have impaired early relaxation, so your E prime velocities go down and your strain goes down. You can have myocardial crypts. And you can have mitral valve and papillary muscle abnormalities that are best detected on cardiac MRI. So the US and European guidelines differ a little bit on whether or not people who are gene positive but phenotype negative should participate in sports. Here in the United States, we've allowed those individuals to participate unrestricted. And then finally, just touch on the risk stratification issues. The US and the Europeans have a little bit different sort of recommendations on how to evaluate patients for their risk of sudden cardiac arrest. There's a big debate about this at the International Hypertrophic Cardiomyopathy meeting this last weekend. But in general, if anybody has had a sustained VT episode or a history of sudden cardiac arrest, certainly they get an ICD. If you have a family history of sudden cardiac arrest and a first-degree relative, extreme left ventricular hypertrophy greater than 30 millimeters, or you've had recent syncope, there's a class 1 recommendation to proceed with an ICD. If you have non-sustained ventricular tachycardia or an abnormal blood pressure response to exercise, that's essentially now sort of de-emphasized a little bit, and that's more of a risk modifier. And if you have additional risk modifiers, you can consider an ICD in those settings. And if you don't have any of these major risk factors, then ICD is not recommended. Europe has come up with a different thing. This is available on the web. The website is listed right here. Basically, it's a risk model. So you put in their age, maximum wall thickness, left atrial size, which is a measure of diastolic dysfunction, and probably getting at whether or not there's a lot of scar burden in the ventricle. Put their amount of obstruction in there, whether or not they've had a family history of sudden cardiac death, non-sustained VT, and an unexplained syncope. And it spits out a number for you that represents their 5-year risk of sudden cardiac arrest. And I think it's useful. I use both of these. I don't think one is superior to the other. I think they're, in essence, sort of companion ways of looking at it and helping patients understand their risk. So abnormal ECG, these are the final recommendations. We go through the history and physical, take that good exercise history, take a detailed family history, maybe do some labs. I didn't talk about the value of BNP, but that can be helpful in some settings. And then we start with an echocardiogram. If everything is normal there, sometimes we can stop, depending on how abnormal that ECG is. Sometimes we get a diagnosis of hypertrophic cardiomyopathy on here or some other diagnoses. And then we do our risk stratification, consider genetic testing. If this stuff is inconclusive, then we go forward with additional battery of tests that can include the cardiac MRI, the Holter, CPET, and we consider family screening. And what I mean by that is actually asking family members to come in and get echocardiograms, and that can sometimes help to understand whether or not there's disease within the family. And then we can talk about deconditioning. Sometimes we get diagnoses there. Sometimes we can confirm an athlete's heart that way. Many times, though, we're left with this diagnostic uncertainty. Maybe we have a distinctly abnormal ECG, but a normal evaluation, and we're going to want to follow those individuals over the long term. We've talked a little about some of the challenges therein. Okay, thank you very much. Appreciate your attention.